Hello friends, this is Nishant Gautam, Associate Professor from the Department of Pharmacology, Government Institute of Pharmacy. Today we will discuss about the plasma volume expenders. Already we discussed this chapter in two parts. Today we will continue the same chapter in its last third part, and as we know, this chapter belongs to your second unit, Pharmacology of Drugs Acting on Cardiovascular System. So, in previous two parts, we discussed about the colloids. Today, we will make our discussion continue with that of the crystalloids. As the name suggested, crystal plus oids means resembling crystals. These crystalloids are the electrolyte solutions with small molecules that can diffuse freely throughout the extracellular space. Relatively low tendency to stay intravascular. The principal component of crystalloid is inorganic salts like NaCl. Thus, 75 to 80% of infused crystalloid is distributed in interstitial space. The volume resuscitation with crystalloid fluid expand interstitial volume rather than the plasma volume. So note this point, this is very important point. The volume resuscitation with crystalloid fluid expands only the interstitial volume rather than that of the plasma volume. The example of crystalloid preparations are isotonic saline, lactate Ringer's solution, etc. Now, let us discuss the types of the crystalloids. They are categorized into the three. Let us discuss one by one. The first one is isotonic crystalloids. When concentration of the particles or the solutes is similar to that of the plasma, it doesn't move into cells and remain within the extracellular compartments, thus increasing intravascular volume. The example of isotonic crystalloids is 0.9% NaCl, Ringer's lactate, and dextrose 5% in water, denoted as D5W. The second one is the hypotonic solutions. Compared with intracellular fluid, that is, as well as compared with the isotonic solutions. The hypotonic solutions have a lower concentration of solutes, that is the electrolytes. These solutions will hydrate the cells, although their use may deplete fluid within the circulatory system. The example of hypotonic solutions are 0.45% sodium chloride, 0.33% sodium chloride, 0.2% sodium chloride, and 2.5% dextrose in water. The third one is the hypertonic solutions. These solutions that have a higher tonicity or the solute concentration. The osmotic pressure gradient draws the water out of the intracellular space, so that increasing the extracellular fluid volume. That's why they are used as a volume expenders. The example of hypotonic solutions is 3% NaCl and dextrose 5% in normal saline, denoted as D5NS. Now, let us focus on the ingredients of the different preparations of the crystalloids. They are made here in this table compared with that of the normal plasma. The normal saline Ringer's lactate D5W is made compared with the normal plasma with respect to their electrolyte balance, like the sodium, chloride, potassium, calcium. In addition to this, the pH of all these and the content of the glucose and the osmolarity with their tonicity. Here, for example, the normal saline has the value of the sodium 154, chloride 154, potassium 0, calcium 0, the pH is 5.7 and the glucose content is 0 and we are not using any buffer and the osmolarity is 308 and its tonicity is isotonic and its typical indication is resuscitation. So here we can make like this the comparison of normal saline Ringer lactate and D5W with that of the plasma and among these also. Now let us discuss the crystalloid preparations one by one. The first one is isotonic saline, that is the normal saline denoted as NS. The NS is a prototype crystalloid fluid containing 0.9% of NaCl. That is actually the 9 gram of NaCl per liter. It is called normal saline solution because percentage of NaCl, sodium chloride, in the solution is approximate to the concentration of sodium and chloride in the intravascular space. Already we discussed in the previous slide in a tabular form, the pH of isotonic saline is considerably lower than that of the plasma pH. The normal saline is frequently used in the patients who cannot take fluid orally and have developed dehydration or hypovolemia. So during both of these complications, we are utilizing the normal saline. The osmolarity of the normal saline is 308 milliosmol per liter of the water. Now, after this discussion, the question arises, when to be given the normal saline? So, the normal saline is given to treat low extracellular fluid, as in fluid volume deficit from hemorrhage, severe vomiting or diarrhea, heavy drainage from gastrointestinal suction. In the condition of shock, in mild hyponatremia, metabolic acidosis, such as in the diabetic ketoacidosis. The normal saline is the fluid of choice for resuscitation efforts. The normal saline is the only fluid used with the administration of blood products. The disadvantage of the normal saline is the metabolic acidosis. Here, note this point. The fourth point already we discussed the metabolic acidosis. In the metabolic acidosis, such as diabetic ketoacidosis, we are using the normal saline. But the normal saline itself having the potency to produce the metabolic acidosis because due to the high chloride concentration, the hyperchloremic acidosis takes place. So, the intraoperative infusion of isotonic saline at the rate of 30 ml per kg per hour causes a drop in serum pH from 7.41 to 7.28 after the 2 hours. So, with this data of the therapeutic range, we are using the normal saline in a monitored manner. Then the second crystalloid preparation is the Ringer's lactate, also called as the Hartmann's solution. Let us discuss some of the features of this Hartmann's solution. The Ringer's lactate was introduced in 1880 by Sidney Ringer, a British physician. The Hartmann's solution was designed to promote the contraction of frog's heart and was contained with calcium and potassium in the NaCl derivatives. The potassium and calcium ion concentration are in appropriate concentrations of plasma. The sodium concentration is reduced for electrical neutrality. The lactate addition requires reduction in chloride concentration, which is a close approximation of plasma chloride concentration. So note this point, the lactate addition is required for the reduction in chloride concentration. In the normal saline, we studied that this chloride is responsible for the acidosis. So here we are using the chloride for the close approximation of the plasma chloride concentration. Thus, the risk of hyperchloremic acidosis with a large volume of infusion of this Ringer's lactate is eliminated. It is contraindicated as diluent for the blood transfusion. Now, the question arises why this Ringer's solution is most physiologically adaptive. It is because of the fact that its electrolyte content is most closely related to the composition of the body's blood, serum and plasma. That's why the Ringer's lactate is the another choice for the first line fluid resuscitation for certain patients. For example, the patients, those with that of the burn injuries are mostly made treated with the use of the Ringer's lactate. Now, let us discuss about when to be used the Ringer's lactate. The Ringer's lactate is used to relapse the gastrointestinal tract fluid losses in case of the diarrhea or the vomiting. The Ringer's lactate is used as a therapy in case of the fluid losses due to the burn and trauma. It is also used in case if there is the condition of hypovolemia and the acute blood loss. Now let us discuss some of the disadvantages of the Ringer's lactate. The calcium content in the Ringer lactate is the major disadvantage because it can bind with that of the certain drugs and inactivate or reduce their effectiveness. Drugs to be not infused with ringer lactate are aminocaproic acid, amphotericin, ampicillin, and the thiopental. The ringer lactate is metabolized in the liver, which converts the lactate to bicarbonate. Note this point: the ringer lactate is metabolized in liver, and where its conversion of the lactate to bicarbonate takes place. It is because we cannot give this ringer lactate to the candidate who is suffering from the liver diseases. Another disadvantage is that the ringer lactate is administered to the patient who have metabolic acidosis, not the patient with lactic acidosis. So, as I noted one point, it is metabolized in the liver. So, not to be given to the patient with the liver diseases, as they can't metabolize the lactate to the bicarbonate. Then the third crystalloid preparation is T5W. That is the 5% of dextrose in water. Generally, the 5% dextrose solution are used, which provides 170 kilocalorie per liter. We can understand with this example, the 1 gram dextrose is equal to the 3.4 kilocalorie. And also we can say the 50 grams is equal to the 170 kilocalorie, as earlier we discussed the 5% dextrose solution are providing the 170 kilocalorie per liter. The 5% of dextrose in water is a IV sugar solution which provides some energy to the body parts. The osmolarity is lower than that of the serum. The osmolarity of the D5W is 252 milliosmol per liter of the water. In continuation to this, the 5% of dextrose in water is considered as isotonic solution. But when the dextrose is metabolized, the solution actually becomes hypotonic and causes fluid to shift into the cells. Note this point: it causes the fluid shift into the cells. Less than 10% of infused volume of D5W remain intravascularly. The two-thirds of infused volume of D5W ends up inside the cells. Further, the D5W predominates, its effect is the cellular swelling. So already I told you to note the point: once the dextrose is metabolized, the solution actually becomes hypotonic and causes fluid shift into the cells. And this is the reason which causes the function is impaired. Now, the question arises, how does the D5W works? The D5W provides free water that passes through membrane pores to both intracellular and extracellular spaces. Its smaller size allows the molecules to pass more freely between the compartments, thus expanding both the compartments simultaneously. This is how it works. Then T5W provides 170 calories per liter, but it doesn't replace the electrolytes. Further, the supplied calories doesn't provide enough nutrition for the prolonged use. So its use is in the hypernatremia and the hypoglycemia. Now let us discuss the disadvantages of D5W. The D5W is not good for the patients with renal failure or cardiac problems, since it could cause fluid overload. The patients at risk for intracranial pressure should not receive D5W, since it could increase cerebral edema. Then the D5W should not be used in isolation to treat fluid volume deficient, because it dilutes plasma electrolyte concentrations. Never mix the dextrose with blood, as it causes blood to embolize. Also, not used for resuscitation, because the solution would not remain in the intravascular space. Now, let us discuss some of the contraindications to plasma expanders. It shows the contraindication in allergy, heart failure, severe anemia, thrombocytopenia, pulmonary edema, and in the renal insufficiency. Now, let us discuss the uses of plasma expanders. These plasma expanders are used in the conditions where blood or plasma has been lost, or it has been moved to the extravascular compartments. For example, in cases of the burns, hypovolemic shock, endotoxin shock, severe trauma, and extensive tissue damages. Further, the plasma expanders can also be used as a temporary measure in case of whole blood loss till the same can be arranged. But these plasma expanders do not have oxygen carrying capacity. So here we discussed in the second point, we can use as a temporary measure. But afterwards, as per the condition of the patient, we have to give the therapy through whole blood as soon as possible, depend on the condition of the patient. So that's the end of this topic, plasma volume expanders. Revise the topic from the book. Have a nice day and